Dr. Collett.
Oh, no, there's a problem here. Oh, no, okay. Okay, I can start?
Yes, please.
Yes, okay. Good afternoon, everybody. I go to present a case. It's a very interesting case that I have make in Hospital das Clínicas last month. When fair play goals get roles, I think it's going to be a very interesting case. Let's go to see it. It's a 53-year-old man. Patient was a collision with another player in a soccer match. He was taken to a level 1 hospital. In the hospital, he presents severe abdominal pain, low blood pressure, and sweating. Respiratory rate in this hospital is 22 EPM. Her heart is 120 BPM. Systolic pressure is around 80 millimeters of mercury. Glasgow Coma score is 40. He received in this hospital ringer 1,015 50 millimeters and 1 gram of transamine. Okay. The time of transfer to this small hospital, level 1, to our hospital is about 120 minutes.
Sure.
In my hospital, the patient has respiratory rate is 22 EPM, saturation is 88%. No breath mask was put, it's a 50 liters by minute. Vesicular murmur present bilaterally. Arterial pressure in this moment is 5.3 by 3.4 millimeters of mercury. Cardiac rate is 130 BPM. Capillary refill time is 5 seconds. Fast exam is positive in the hepatorenal and suprapubic space. Ringer was repositioned and start norepinephrine 30 milliliters by hour. Glasgow Coma score is 30. Pupil is normal. The pill is sweet. And the abdomen with signs and peritoneal irritation. Here you can see the patient. The fast exam here you can see small hemoperitoneum. Next. The blood gas exam is 705 pH. Bicarbonate 30.8. Bexessence minus 16.1. Arterial lactate is 110. So, what to do with this man now? Dr. Cassim?
Thank you, doctor. It's a very intriguing topic. When I first saw that, I said, this must be interesting. And of course, it is coming from you. It surely is going to be interesting. So, there are several things that we want to discuss here before we go on to do what to do at Dr. Collett's hospital. Even before he gets there, when he goes to the little hospital, there are things that was not done properly. So let's start with Dr. Untrak. If you were in that little hospital when you see him, Dr. Untrak, what do you think would be the right thing to do there?
Yeah, so I was looking at that. First of all, a couple of concerning points, not just the tachycardia and hypotension, but also the tachypnea. So whether you're a surgical patient, either trauma, non-trauma, or a medical patient, tachypnea is, you don't get to be tachypnic unless something's terribly wrong. So that's a very bad sign. They gave him the TXA, 1 gram. Normally it's 2 grams. So but they were thinking on the right track. And then the 1,700 cc's of ringers is too much. Now, did they call your hospital, Dr. Collett, before they transferred? Because I think what they should have done was to pick up the phone, call the tertiary care center where they're going to refer, because they could have, what I would have asked them to do was to give them a 2nd gram of TXA, stop with the crystalloid, and give him, if they have whole blood, fine. If not, 1 or 2 units of packed cells, and basically 1 to 1 to 1. But if whole blood, 1 unit or 2 units would be fine. Transfer them and then send him in the ambulance with another unit so they can give it along the way if he gets hypotensive again. That's what I would have done differently there. If they have means to do, they probably don't have a CT, and if they have an ultrasound, they may not be very good at doing the fast exam. But the only maybe just a chest X-ray to be sure that he doesn't need a chest tube. And I don't think he probably. You didn't mention anything on the EFAST about a hemothorax, but that's what I would have done differently. A 2nd gram of TXA, get some blood, preferably whole blood if they have it. If not, some blood products, and start to transfuse him. So, with a 2-hour transfer, it's better to get ahead of the problem and send him with a couple of units of blood that they can give along the way. And I agree, didn't need to be intubated because he was awake. Glasgow Coma Scale was still good enough when he got there. But I'd be concerned about the tachypnea. If they didn't know why he was tachypnic and hypoxic, then perhaps it wouldn't have been wrong to intubate him before sending him out.
Well, in medicine, we have a saying. It says, primum non nocere. Don't do any harm. And they certainly did not follow that dictum, that we are not supposed to do any harm to the patient. Perfect, Dr. Untrak. Dr. Burke, are you available to discuss this case? Or anybody else want to discuss this case? Okay, I totally agree with Dr. Untrak. Everything he said was the pearl. Residents should take it. That is how you approach when a patient like this comes to a hospital where all specialties, all the up-to-date technology is available. You are working in a small hospital or in austere situation. This is how you manage the early intervention before you pick up the phone and ask for a transfer. Okay, now that he is arrived at Dr. Dr. Collett's hospital, and he is still hypotensive, I mean severely hypotensive. I would say he's in 3rd or 4th degree shock, and he's acidotic, and lactate is sky high. And so where do we go from here, Dr. Untrak?
Yeah, so first of all, Dr. Collett, did they call your hospital, or did he just arrive at your doorstep?
No, they don't call our hospital.
Okay, well, that's good for follow-up, because you would have, obviously you would have had them do all those things, a 2nd gram of TXA, some transfusion before he goes, and then send him with some blood available, with IVs in. But in this case, so you need to catch up. He's got a high lactate, and he's bled down. He's 53 years old. Presumably, he wasn't starting out with a hematocrit of 30%. So if you have fresh whole blood, I would give him a few units of that, and basically order a massive transfusion protocol. And he needs to go to the OR, but the option is, with that degree of shock and it's prolonged, you can temper it. If he doesn't respond to the blood transfusion before going off to the OR, you might consider putting in a Reboa in the zone 1 position, just to temporize, and off to the OR, and then get into the abdomen, find out what's wrong, stop temporarily stop the bleeding, and then you can deflate the reboa. But that would be an indication here. If somebody's in shock, he's not making urine, and you need to temporize a few minutes, and you can do it quickly, reboa, but I think you don't have it there. So in that case, just off to the OR right away with blood running.
Dr. Burke, just to summarize this case, this is a soccer game, and the gentleman he's 60 plus years old. The gentleman got hit in the abdomen, and he goes to the local hospital where they gave him copious amount of fluid and 1 gram of TXA, and then put him in the ambulance, and he marched for 2 hours before he reaches Dr. Collett's hospital, and he is still in profound shock. So that is the summary of the case. So now we want to know, he's in shock, profound shock, and he's in Dr. Collett's hospital. Would you like to add anything more that you would like to do, Dr. Burke?
Sorry, Dr. Kasim. I'm kind of in and out of the presentation. I'm in a hotel room going in and out. So I'm trying to catch the pearls, but I cut part of what Dr. Untrek said, and tachypnea always makes me extremely nervous about what is going on, and that there's a limited amount of time to figure it out. But I haven't cut enough of the presentation to comment specifically on it.
Okay, so what I would do in a case like this would be, I would be pretty angry at the other hospital, but put that aside, I need to take care of this patient. He's in profound shock, and there's nothing better than I need to do other than replenish his blood volume, because I know from the ultrasound he's got fluid in the abdomen. The fluid is blood till proven otherwise. And so blood needs to be replaced by blood. Fill up the tank, and while you're filling up the tank, make sure that you get the OR ready. I think in most hospitals, Reboa is not available, and even if it is available, it is time consuming, and I would not do anything like that. I would rush him to the hospital and talk to the anesthesiologist and tell him, this man is in profound shock. I need to open his abdomen. So we need to do this in concert, so that he doesn't become a candidate for cardiac arrest. So don't intubate him till you are ready. When you're ready, perhaps you should do a very gentle anesthesia. And this is hoping that you have done a chest X-ray to make sure that you don't have any pneumothorax or tension pneumothorax. And then you can work with the anesthesiologist and yourself and open the abdomen through a midline incision and find out what most likely is bleeding. You should have some clinical acumen here. More than anything else, it'll be either liver or spleen. That's where the blood loss is going to come from. And then you can at least stop the bleed. The name of the game is Stop the Bleed. Dr. Collett, would you like to carry on, sir?
Yes, I want to carry on. I think something important. I believe this patient has a blunt abdominal trauma, but this patient is 53 years old man who make me a game of football or soccer. Sometimes we have some people have some acute myocardial infarct, ischemia, and maybe sometimes the patient may have some aneurysm, aortic aneurysm. Then during the player, they may become a rupture. Sometimes it's very important in this situation to make me and the small hospital initial assessment maybe discharge acute myocardial ischemia, and then because sometimes this may be confused. for the differential diagnosis. So I believe to do the things that Dr. Huntrak says and Dr. Kassim, but in these situations, I see the patient is in shock. So I decide to take these patients to OR. I make intubation in OR, in the surgical theatre, because I don't want to make in the emergency room intubation in this patient. Maybe this patient is not good to make in this position, in this room, maybe start oral intubation. So I take these patients to the surgery, and that's what I found. You can see here is here. I can see is the column, transverse column, the great momentum, and the retroperitoneal, this retroperitoneal big hematoma, small amounts of the fluid in peritoneal cavity, but it is very, very big hematoma in this position. You can see here. It's very difficult to assess the supramesocolical organs. You can see the size of the hematoma here. Very nice, very beautiful, very big hematoma in the zone 1. So at this moment, I don't know what to do. I want you take your experience to tell me what to do, please.
Well, Dr. Collett, was the hematoma pulsatile?
It's not. It's too big to see this is pulse valve. I don't.
Okay.
Okay, but it's very, very big hematoma. It's very difficult to
So-
assess the left side of the abdomen. You cannot assess the size of the hematoma. You cannot assess the supramesocolical area. It's very difficult.
Well, being a vascular surgeon, when I see something like that right in the center, and then of course the penny will drop very quickly. Hey, am I looking at something more than splenic injury or liver injury? I want to have a little peek at the spleen to see if it is bleeding. If it is not bleeding, then I move to the liver, look at the liver, and if it is not bleeding, then I will become suspicious. This is something that I have seen before. This is what I see, something central. So what are the structures right in the center that will give me such a big hematoma? And hopefully if it will be pulsatile, if it is not pulsatile, of course I'll be still thinking that this may be a pre-existing condition such as, like you mentioned, a AAA, and just a blunt trauma caused it to rupture. Or he may have had a splenic aneurysm, one of the splenic artery, and sometimes they form aneurysms, and they rupture as well. And those are the two structures that I will be thinking of. But anything is possible. More than likely, it is a AAA or a splenic artery aneurysm, and then I need to deal with it. Dr. Untrag, what do you think?
Yeah, so first of all, let me say it's just when you started to talk early on, I was realizing, yes, I should have thought of, in a 53-year-old man, do an EKG to rule out an MI. On the other hand, he probably, if he had active coronary disease, he probably would not be, and he looked kind of vigorous, that he would have been playing soccer, as we call it. But it's still possible that after the collision, he suffered an MI. And excellent point. It still wouldn't change your need to operate, but you could, do certain things like keep the blood pressure up, whatever. But the EKG should have been part of the workup. I agree with that. It was excellent. But anyway, in this case, you're in the abdomen. I think you should be able to rule out AAA very quickly. If you had a ruptured aneurysm, you just put your hand between that, on the top half, that omentum with the hematoma on it, and the bowel, small bowel to the bottom. Slide your hand down. along the ligament of trice. You should be able to feel right away. If there's an aneurysm, it'll be bulging out in the lower, just to the near the midline of your incision. So you can rule that out. But in any event, the goal at this point is, open, scoop out the clot, suck out whatever blood you can, and put some packs in and let the anesthesiologist catch up. So I'm assuming that now, after you've transfused him and his blood pressure and pulse are responding appropriately, is that the case, or is he still going into uncontrolled shock, not improving? What's the scenario now, Dr. Collett?
Sorry, in this scenario, I can see the patient here has a very big hematoma in this area, in central area, above the mesocolon. The colon is upper. I can assess the aorta near the esophagus, near the hiatus. I cannot see the aorta near the duodenum. It's not possible. And I see the hematoma comes to the left side of the colon, So it's very difficult to approach any exposure.
Yeah.
Yes, yeah. My thought initially is maybe this abdominal aorta ruptura, a aneurysm that patient maybe have, and then novel investigation. There's acute care. So there's a problem, very difficult to know what to do and how to control this hemorrhage and how to approach this hematoma.
Yeah, but physiologically, that's what I was asking. Is he still in profound shock, not responding to transfusions?
Yes,
Okay.
yes, continuing profound shock.
Right. So in this case, I would just put my hand up to the hiatus and try to get proximal control of the aorta and the upper abdomen, do that. And even with a ruptured aorta, the Reboa was developed, I think, the 1950s to deal with that problem. So, and I think you don't have it there in Brazil, so you couldn't have put it anyway. But I would go ahead and get control with an aortic tamponade, have a junior resident hold that compressed, and then it looks like you have a pretty generous incision. Then it's to the hematomas to the left, so it looks like the problem may be in the retroperitoneum. And once you get control of the aorta and then improve his blood pressure, his hemodynamic status, go ahead and try to explore better. So eviscerate the small bowel and move the hematoma to the patient's right, and then see if it looks like it's retroperitoneal. Then with control of the aorta, I'd go ahead and do a left visceral rotation and start to explore. But you got to get initial crude control of the bleeding, whether by packing, proximal aortic clamping, and then catch up hemodynamically. Otherwise, the patient's not going to do well.
I would like to add one other thing. I think I would do all the things Dr. Untrak mentioned, and sometimes it doesn't work. You don't have a junior resident available to put the aortic paddle on and get control of the aorta at the hiatus. And even an experienced surgeon, sometimes they have difficulty in putting his finger and hooking the aorta and put a Straczynski clamp around it. And time is of essence here. This man is going to have a cardiac arrest any minute, and you need to get control of that aorta. And if you are going to be wasting time, you're going to lose the patient. So you have to have plan A, plan B. Plan A being get control very, very quickly at the hiatus. If you're not getting control, then you have to do an anterolateral thoracotomy and go into the chest and control the aorta. That shouldn't take very long. You just get in and put the clamp the aorta. At least you get control of the aorta, then you can open up the humongous hematoma Dr. Collett is showing us. Dr. Burke, are you available?
There's also a comment in a couple of comments in the question. I'm sorry, a couple of comments in the chat.
Okay.
Okay.
And Judy says preoperative Reboa Dr. Judy Irbo is not available in Brazil.
Yes, Hebo is that I don't have here. Is not
Yeah.
is not used here.
No,
There is on-
Riboa is not available, so you have to
No.
come up with something else.
No, but I
Yeah.
think she was trying to say that it's dangerous because you don't know the condition of the aorta. And that's actually true if you don't know the condition of the thoracic aorta. So if it's an auto accident and you don't know that you don't have aortic rupture near the ductus arteriosus, if you put the Reboa up there, then it'll convert a contained rupture to a catastrophe. In the abdomen, if it's a ruptured AAA, I think Reboa is acceptable there because there's usually a channel and it slides right up past the area of rupture, and then you get control. It's like proximal control. But anyways, it's moot because it's not available.
Okay.
Okay, Dr. Collett, carry on, sir.
I want to continue because it's very interesting case because it's very difficult to assess the aorta through the abdomen. It's very difficult. I have juniors residents there, but it's not possible to put my hand near the hiatus. It's very difficult. So the hematoma is big, the patient is big, but the hiatus is very, very difficult to assess. So let's go to what I do. I make anterolateral thoracotomy. Maybe here, maybe anterolateral thoracotomy here. You can see the phenoketo. And then I could approach the hematoma. It's very difficult. I don't know what is in this position. Medial, near the duodenum, and near the aorta. So we would find the aorta near the duodenum now. Here's the clamp. We release the clamp, and you can see I can put a vessel loop near the aorta here. And then we found this structure here in that hepatoperitoneal area. Here, I take off. It's the kidney, the left kidney. Here, I try the renal artery, renal vein here. And control the hemorrhage here. Can see the duodenum, the colon now, can see the hepatoperitoneal, the spleen. Now we can realize the hematoma can easily go into the peritoneal cavity. So there is blood come, a small amount of blood come for the hepatoperitoneum. I put pads here and tamponate this area and put a peritoneal vac. Here, peritoneostomy, make the abdomen open. Here can see close the chest. There is no injuries in the chest. This is what to make the peritoneostomy. Put the chest tube, close the chest, and make the abdomen open. Here you can see this is a kidney, is a hydronephrotic kidney that was injured through the game. Someone can comment as what see? Dr. Kassim?
That looks like a dog's food. So, are you telling us that you did a left nephrectomy? Is that
Yes,
a nephrectomy?
nephrectomy through the midline.
Oh,
No rotated the colon, nothing. Because yes, sometimes here you can see the colon. When you take out the kidney, you open the hematoma, you can see the colon, the hepatocolical part. I can see it's very, very easy to now to see, but it's very, when you see the hematoma in the midline, and this is a position, it's very difficult to know what it is, but it's always, we found a kidney, We start hydronephrotic kidney after we can control the hemorrhage. And then the blending from the hepatoperitoneum, I put pads and the peritoneostomy and close the chest. It's very important here because to show what's happened, this is the pressure at the end of the surgery. You can see the patient will receive a small amount of the noradrenaline, but they make this stable. Let's go to show what we receive. Crystalloid 100, plasma light. I don't like this, but the anesthetist love it. 200 milliliters, 6 head ball packets, 5 plasma, 1 ferris of platelets, transamine, fibrinogen, gluconate with calcium, and sometimes here, I don't know because the anesthetist wants to go to take albumin for this patient. Here, you can see, well, yes. Here is the blood gas, 2 hours of the surgery, during the surgery, and 4 hours, the surgeons have end, the patients, the pH is maybe stable, the Baker's essence become normal, and lactate decrease. This patient, after surgery, cardiac rate was 101 BPM, arterial blood pressure is 121 by 60.8 668 millimeters of mercury, saturation is 100%, and she was receiving 1.80 microgram by kilogram minutes of norepinephrine. That's at the end of the surgery. What to think about the reposition and the condition of the patient? If you have something different to do, I want to know.
Dr. Untrack.
Yeah, so beautiful numbers. First of all, the norepinephrine, it looks like it's a homeopathic dose, as we would say. I mean, it's really minimal. So I would turn that off. But anyway, so the bottom line is you couldn't get control of the aorta at the hiatus. So you did a thoracotomy, and when you clamped the aorta, the blood pressure became normal. Is that or improved? Is that right?
Yes.
Okay, so this is a very, very strange case. It's a collision playing soccer, and the spleen didn't rupture, but the left kidney did. So that would suggest that there was some underlying pathology, with whether a big cyst or for some why it was so fragile that it ruptured. And it wasn't. Was it an avulsion at the hilum, or just disruption of the parenchyma, like a grade 4 disruption? What was it?
I don't know, because there is a very big hematoma. When I can catch it, is I try to close the hilum. I don't see the correct. Yes.
It looks like from your pictures, you had a nice control of the hilum. You ligated that it wasn't avulsed from the hilum, but just total disruption of the parenchyma. And I wonder whether, what the pathologist thought, but it suggests that there was, for some reason, why it was so fragile and it ruptured, but the spleen didn't rupture. So that, there must have been something wrong anatomically with that kidney that this is what happened. But so I think it was a great job. Now, when you entered the abdomen, I think that you could see the big hematoma coming from the left side as a retroperitoneal hemorrhage. You can see that. So, and you were there, you're expert surgeon. So I defer to you that there was no other way but to open the chest. At first I would be inclined without, if I were saying that myself, remove the viscera, the small bowel to the patient's right side. The kidney is going to be right where you accessed it, ultimately after you clamp the aorta. So, eviscerate, and you see the hematoma there, pack the hematoma, apply pressure, and then the anesthesiologist should be able to catch up. So, I think it's perfectly fine to open the chest. You might have been able to avoid it. And then Reboa gets a bad rap, just like Lap Coley did when it was first shown. in 1989, and surgeons were laughing, and then 2 years later, everyone was doing it, you know, and you don't have it there anyway. But this is a very good indication for it. You know, a patient is a non-responder. You can rapidly get access to the to control the aorta, go up to the OR. Then you would have saved the time and avoided the thoracotomy. So a non-responder who's bleeding from the abdomen, and he's got a, you know, should be able to feel a pulse. That the experts that do this all the time say that, you know, you really, with a little practice, you should be able to get access and have the Reboa in 2 or 3 minutes, you know, so that less time than it takes to do the thoracotomy, and you can get it done in the ER when the patient presents. So this would be an ideal indication, but it was a really, really unusual case. And, you know, I think if you were doing your own fast there, they'd, or you did the fast there, so you didn't see, I guess it was positive initially on the right side, so you didn't bother to look on the left side, but you would have seen a huge hematoma where the kidney's supposed to be. You know, when you look, you know, if you would have looked on the other side, probably you stopped after it was positive, Dr. Collett. Is that correct?
Yes.
Stopped with the ultrasound after you saw on the right side the hepatorenal pouch was.
It's very difficult to make the ultrasound in this patient because this patient is very shocked and he's also very agitated. It's very, very, very difficult.
Yeah. So what you did, I think it was, you know, a typical Dr. Collett case, an unusual case. And I love Dr. Collett's presentations because he has not only a crack OR team, but he has a total intraoperative cinematography team. He always has the best videos that shows everything going on there. And we can actually see with our own eyes what he saw. So it was great, a great case.
Thank you.
There is a question in
Well-
the chat from Dr. Kobe asking how long did it take, Dr. Collett?
Dr. Kassim?
Dr. Collett, there is a gentleman from Japan. He's asking you, how long did this operation take?
An hour and a half.
There you are. Well, let me chime in. First of all, only Dr. Collett can do something like this. I mean, and in inexperience, or even a seasoned surgeon will be sweating bullet in a case like this, not knowing where it's coming from, what the presentation is, what shall I do next? But he was so swift. You know, he went into the abdomen, saw the situation, assessed the situation, said to himself, hey, this is too big, I can't manage it, goes straight into the chest, puts a clamp, control the aorta, comes back to the abdomen, finds where the pathology is. Amazingly, it is an organ that we usually don't see very much of, a ruptured kidney. The whole kidney looks like a dog food. And he does a nephrectomy and closes the abdomen and saves the patient. It's fantastic case. So what I'm thinking is, did this patient have a pre-existing problem with his left kidney? Before I take out the left kidney, I have to be absolutely sure that he's got a functioning right kidney. You know, did you have any doubt that you're looking at the unilateral left kidney problem and the right kidney is perfectly okay, that you're not going to take out the left kidney and then the patient doesn't have a right kidney?
In this patient, Dr. Kassim, I think when I have a blooding coming or a shock coming from the kidney, from anywhere, today, if 40 years ago, I tried to check if he has another kidney, but in this moment, I don't check it because if the patient have gold, I have hemodialysis, I have liver kidney transplantation, I have any problems to recover the patients, but I don't recover the patient who is dying for hemorrhage. So I think in this, you can think about control the bleeding, take off the kidney, and then you can, today you have other substitute the kidney function. So I think it's very important. You have no doubts that you have to control the hemorrhage in this patient very quickly.
So now we need to know what you found out about the left kidney that you so diligently took out like a breeze and saved the patient's life. What was the pathology in the left kidney?
I go to continue the case because I think it's very interesting the end of the case. But
Please do. Please
yes,
do.
yes, I think the great problem in this situation, this kidney, this has a kidney with disease. It's not a normal kidney. Okay, the patient was admitted to the ICU, decreased vasoactive medication, 5 hours, he was extubated. And here, the CT on the next day, you can see the no problem in the chest. The chest tube is on the left is normal. Here you can see he has the spleen, the kidney, his kidney. Here is the pads in the kidney, where was the kidney, as a small amount of blood in the small amount of the fluid in the abdomen. And then here can see the reconstruction. Here you can see the kidney, the right kidney, and you can see there's stop blending, and the pads is okay, contaminate the retroperitoneal area in this situation. So I'm going to continue because it's very interesting here. What to do in this situation is about to ask how long we will wait to review the second look of this patient. I go to continue because it's, I think it's very important that when the patient was stable, there is no, the temperature is normal, the blood gas is normal, and the coagulation is normal. I take this patient to OR, maybe 24 hours or 48 hours. It's not very problem. This patient went to 36 hours to the OR. Here can the chest close. Here's the abdominal open, take off the pads. Here take the pads. Here's the kidney. Where is the kidney and the retroperitoneal area? And in our service, usually in this situation, I may put a preperitoneal, pre-aponeurotic smash for avoid evisceration. Is our sometimes in our service there is a work that says it's safe to avoid evisceration in patients who have peritoneostomy. Here you can see put the mesh here, they close the abdomen, and here is the evaluation of the patient. Patient without vasoactive medication is tubated in the first, second surgery on the second post-operative day. The diet was introduced on the third post-operative day. Chest drain was removed in ICU and discharged on the fourth post-operative day. And the patient was discharged on the 10th post-operative day. This is the creatine and urea from the patient. At the 10th post-operative day is normal. He is the patient on the fourth post-operative day. Can see the incisions, very nice. And I want to know the comments about this case. Dr. Cassim?
Doctor, oh, what a fantastic case. I mean, those of us who missed listening to Dr. Collett present today, you definitely missed a real pearl here. There's so many things you could have learned from this case, how to manage a difficult situation like this. And he showed it methodically, how he approached professionally, remarkable result. And I would dare to say, if this patient had have ended up somewhere, he would have died. I think it was a fantastic save. The whole case, the way you approached this, I just take my hat off to you, Dr. Collett. You're a magnificent surgeon, one of the best. Fabulous case. Thank you so much. Dr. Untrak, what do you say?
Yeah. So to go back to your last question, Dr. Kasim, about the condition of the right kidney before doing the left nephrectomy. Obviously, I agree with Dr. Collett. If somebody is exsanguinating from a left kidney that looks like dog food, it's got you have to do it. You have to do a nephrectomy, but. Initially, he saw at least the upper half of the right kidney on the fast, and it looked totally normal. The right kidney did. Now, you didn't check for perfusion, whatever, but if there's a right kidney there, it looked normal, the size was normal, it wasn't shrunken, and the echoes were normal. And if he was making urine during the case, I assume he had a folium, then I would be confident that he's got a functioning right kidney, because that left kidney was not functioning. It was just bleeding. And, but, as Dr. Collett say, you can live with anephria on dialysis, but you can't live with a kidney that's uncontrollably bleeding. So, that's a good point. But I still would like to know what the pathologist, did he say, okay, macerated kidney, but the histology sections didn't show anything, right? And then he anatomically didn't show anything.
The pathology says it's hydronephrosis kidney with atrophy of the parenchyma and only some. There is no other comments.
Okay,
Only hydronephrosis is the parenchyma that can see in is atrophic parenchyma of kidney is normal. There is no problem. His problem is patients have congenital injuries or polycystic injuries of the kidney, and because it's usually when some people have polycystic kidneys, you have a blood trauma. There is a rupture. It's more easy rupture of the kidney than the other organs.
Okay, so it was a polycystic kidney or hydronephrosis? Which one?
I think they think because a very, very macerated kidney, they told us this was hydronephrosis.
Hydronephrosis.
Yes.
But that also, I imagine, if he had like a UPJ obstruction, ureteropelvic junction obstruction, or if it was severe hydronephrosis, then I imagine that would be a cause for perforation, just with a lot of tension on the kidney, although hydronephrosis, not complaining of pain in advance, not chronic pain, antecedent pain, but still that would suggest. So, that kind of answers the question that he had something initially wrong with the kidney, it ruptured. So there you go. But great case. I mean, I think it's just you're in a situation where you have the best of the best in Brazil. Certain things you don't have. Many hospitals in America are in the same position, but you can still, it's the people do the surgery, not yet machines. Robots eventually will replace us, but not yet.
Okay, everyone, I went ahead, and if you haven't seen yet, for the CME credit, I went ahead and put the information in the chat. The first link has the actual link for the CME credit. But before you do that, the second thing I sent gives the instructions on how to, if you're not already signed up on the Cloud CME, or if you did but it's expired, use those instructions below. And then after you do that, you would go ahead and then enter the link, the first one I sent you, the one that has that link that ends in 18648. And the CME office let me know that the CME link expires 72 hours from 12 noon today, from the meeting time. So please go ahead, and as soon as you can, go ahead and put in your CME information. And I guess if you have any issues, please let me know.
Okay, if I can ask Kevin, then about the sessions before today.
Yeah, I asked that question and got a very fast statement saying that if it wasn't approved prior to the meeting, there's no way to give credit for meetings in the past. Yeah.
All right, at some point, can we, if we email you, can we get a list of our attendance at those, at least for maybe for
Yeah.
the year, and then we can claim category 2 CME for those.
Yeah, because I have a participation list for every meeting. So if you
Okay.
attended, then absolutely, yeah.
Okay, I'll send an email for that, whatever. There's no rush.
Okay, great.
Much appreciated. Okay, thank you.
Sure. Dr. Collett, thank you very much. And unless anyone else has any other comments or questions.
Okay.
Dr.
have-
Collett, thank you so much for sharing this case with us. It is an educational case. Those of us who missed it should go back and look at the archive and look at the discussion and the presentation, and also look at the way you manage this case. It's a brilliant case, and the management was flawless. Once again, you show us that you're a fabulous surgeon. Thank you so much for sharing your case.
Thank you. Bye.
Thank you.